I'm Jimmy Apple, the EMS Avenger. This is EMS Avenger 20 Minutes to Save the World. I have Dr. Peter Antevy with me. He is the medical director for Palm Beach County Fire and Rescue in Florida, also the developer of the Antevy hand and the Antevy system, which many people are familiar with. I think that we can save the world today with progressive CPR practices and resuscitation practices. And Dr. Antevy, I really appreciate you being with me. And something that I wanted to mention before we get started was that we've actually known each other for probably 7 or 8 years. We first met at the South Carolina Resuscitation Academy, which was put on in cooperation with the Seattle Resuscitation Academy. And something that I was thinking about when I was trying to work the angle and getting to talk to you was that we often look at progressive practices and the things that impact survival, such as the practices that you have in Palm Beach County Fire and Rescue, such as HPCPR, early defibrillation, that sort of thing, dual sequential defibrillation. But when you really think about it, you have Seattle's Medic One program that has passionate, dedicated people. And so they put their own practices in place and then created a system to teach those other people those practices. They activated a whole bunch of people, including Tom Bouthole, who then, with Hilton Head Fire Department, puts on the South Carolina Resuscitation Academy, which we both attended. I know you got a lot out of that. I remember talking to you there. To me, I was completely activated by that, and I have dedicated a lot of my time to teaching and spreading awareness to progressive resuscitation practices and evidence-based resuscitation practices. And you have an amazing amount of content out there, your own studies, circulating other studies, spreading the word on evidence-based practice for resuscitation. I think one of the biggest tools that we have in our toolbox really is the passion that we as providers have for resuscitation, because when we get close to each other, we activate each other and we spread that awareness. And that's, I think, one of the biggest single contributors to survival in the U.S.
I agree, Jimmy. When you get people who are thinking similarly in the same room, and you start to see others around you and what they're doing and how excited they get, that is a powerful kind of fuel that when you get back home, you end up doing much more.
Every year in the U.S., there are a little over 350,000 cardiac arrests. And about 90% of them are people that will not be successfully resuscitated. They will not go back home to their families. They will be somebody that are dearly missed by this world. And many of those people didn't have long-term health issues. They had a sudden problem that potentially could have been easily corrected by a dedicated EMS service and by a dedicated community. I don't want to diminish the role that our communities play in survival, because without bystander CPR and early AED placement, the numbers that we like to be proud of in EMS don't look the way they do. But still, a service like Palm Beach County Fire and Rescue has some pretty impressive numbers. And just reviewing what your approach is, you do HPCPR, high performance CPR, early defibrillation. And I don't want to bury the lead here, so I want to make sure that I pump this up. No epinephrine in shockable rhythms. And then you do dual sequential defibrillation for refractory VF and esmolol for refractory VF. So just tell me a little bit about Palm Beach County Fire and Rescue's approach to cardiac arrest.
Yeah, it's been a labor of love, meaning that if you look at what the American Heart Association has put out for many years, what people know as the ACLS guidelines, what many people need to understand, Jimmy, is that those guidelines were made based on majority of in-hospital cardiac arrest care. These are guidelines that are done based on studies done in ICU. The people who write those guidelines are ICU physicians. Maybe you'll find a token, EMS doc on those guidelines. The problem is that what we do, out-of-hospital cardiac arrest, is a very different animal than in-hospital cardiac arrest. With in-hospital cardiac arrest, let's say in an ICU, those patients have been fully resuscitated from a fluid perspective. They usually have an arterial line. They usually are already intubated, and then they go into cardiac arrest. So you can only imagine that coming to a home where the guy's stuck between the toilet and the wall, and who was, let's say, unwitnessed, and he's in asystole or he's in VF, that's a very different call than being called to the ICU bedside because the same guy now is in cardiac arrest, fully lined up and intubated, and etc. And so what we have recognized is that we are now looking at research that perhaps didn't make the guideline. And that barrier of making it into the guideline is fascinating to me because I don't know why they picked this study over that study. And when you look at the studies that they overlook, many times they're looking for RCTs, randomized controlled trials, the large studies, but oftentimes they don't. They just make a recommendation that's based on a small observational study. So when you look at what we do in Palm Beach County, I'll go through the list just like you did, one by one. But the table stakes is high performance CPR. I will bet you today, if I walk into an agency as a consultant and say, "Are you doing high performance CPR?" and they say yes, you really got to dig deeper to see, are you really doing high performance CPR? And I think that to answer the question, if you're listening to this, it's, are you measuring what you're doing? If you have a life pack, do you use CodeStat? If you have Zoll, are you using case review? Meaning that, do you know every compression, every pause, every ventilation, your chest compression fraction? Do you know your depth? Do you know your recoil? If you're not looking at that on every arrest, then there's no way you can be high performance CPR. A friend of mine out in Toronto said that they just turned on the Zoll case review in their hospital, and you wouldn't believe, Jimmy, what their chest compression rate, the percentage that was in range, meaning between 100 and 120, was only 2%. And that was a 14 code. They spent months training on it, and then they only got up to 15%. So they had no idea how bad they were doing. So that's just number one. High performance CPR is a whole topic in and of itself. But
I am going to pause you there because I want to capitalize on that, which is that
yep,
high performance CPR is more than just a conceptual approach to cardiac arrest. And I think that some people think it is, where it's like, okay, I'm dedicated to cardiac arrest, so we're doing high performance CPR, and it's not just the data, it's doing everything perfectly. And I want to give you an example, and you're going to be familiar with example. I'll try to make it somewhat anonymous, but there is a service where you discussed a case with them and made a video about it where we reviewed this cardiac arrest that happened in a store. And something that I clocked in there was they mentioned that they leave the AED on when they get there, and they allow the AED to evaluate the rhythm, and they don't place their own pads on there, go to the cardiac monitor. And we watched in this case where this AED just screwed the pooch for 15, 30, 45 seconds attempting to evaluate this rhythm while responders were in weird positions performing CPR, not getting the patient to a place where they could work. And I was like, that is not high performance CPR. Your perishock pause was like a minute. So yeah, high performance CPR is doing everything perfectly.
right. And if you don't know how many pauses of greater than 10 seconds you had in the entirety of the code, you're not doing high performance CPR. And the problem, and I have to say, unfortunately, is that those pieces of software which are embedded in those machines, those very expensive machines, they're an additional cost. So many agencies, oh yeah, we have Zoll, we have a life pack. Yeah, but do you have case review or do you have CodeStat? No, we don't have that. Well, go buy it, right? Go buy it, and then we can start to talk about high performance CPR. So I agree with you that you need to know second to second, minute to minute, everything that's happening. And again, we've created webinars on this, videos on this. I'm happy to help people offline. Very easy to do. And then, but the hard part is then going on that journey to fix the problem. Okay. Number two, early defibrillation. And people are like, oh, that's common sense. Well, let's kind of put aside the fact that most AEDs in this country are not put on by bystanders. And therefore, when we get there, and you have a patient who's in a shockable rhythm, one of the KPIs or the key performance indicators of how you're doing as a department is how fast from the moment you got on scene until you actually shock that patient. That is a new metric for us. When we started looking at it, well, I thought, of course, it's going to be within a minute or two. No, it wasn't. It was like 7 or 8 minutes. And you think
Wow.
to yourself, how could it be that a high performing agency wasn't getting defibrillation quickly? And it's because we were never telling our crews that number. Now it's a competition. We had one of our amazing EMS captains. She's amazing, Ada. Basically, got to a high school 3, 4 weeks ago, and from the moment she got on scene until that kid got shocked, 56 seconds, right? You think the whole department wasn't made aware of that? Of course they were, because that is what we strive for. One shot got this kid back. Um, if you look at the numbers from Norway, from the Netherlands, those folks have such good outcomes. They have tripled the neuro intact survival. So in 2023, the United States had an 8.1% neuro intact survival from cardiac arrest. In the Netherlands, it was 25%. What?
That's amazing.
That's CPC 1 or 2. What are they doing differently? By early bystander CPR, they have an AED put on the patient to the tune of like crazy number, like 50, 60% of the time. So the faster you do things, bystander CPR, defibrillation is important. So just to go back to what we do, we now measure that time on every single shockable rhythm, how fast we get the first shock on.
So, time to first defibrillation. That's something that we're going to start putting out there to other people to start tracking that time to first defibrillation. And you're right. If you don't have a process for getting to that first defibrillation, then you're not going to see good timing in getting to that first defibrillation.
Right. And the loop is that when you're a medic and you know that after this call, someone's gonna call you up and say, "Hey Pete, we saw that you was 5 minutes until that first shock." They're already now thinking en route to the call about that phone call they're about to get. Every time they do a compression, they know that by the next shift, they're gonna get a full summary with an email saying, "Hey, this was great, but here's some opportunities." It's automatically, that's the loop that you have to create. You can't just say we do high performance CPR. Like you said, I love what you just said. It's not just a philosophy, but it's data driven, and you can actually see it, and you can work on it, and you can improve it. Okay, so moving down the list is the removal of epinephrine for shockable rhythms.
Do you
What most
place
people,
I want to get back to defibrillation. Do
yeah.
you place your pads anterior lateral or anterior posterior?
So we go AP right off the bat for a few reasons. Number one, the data from the DSED trial, Dr. Sheldon Chesky, the great guy, he showed that AP has a lower impedance. What is impedance? It's basically for the electrical current to get through all the skin and the fat and the tissue and the muscle. It would be better if it had less things to go through. And when you put the pad AP, you could see the impedance on the PCO file from the monitor. You could see that the impedance is lower. So AP, lower impedance, and it's better. However, his study wasn't set up to determine whether you should go AP first, but based on what his data showed, all of us have now moved to, at least all of my agencies and many other agencies are doing it too. We're going AP first. Again, that
And
RCT did not show that, but we
sure.
know that's the better thing to do.
And I'm betting that the
And
other reason is to set yourself up for dual sequential defibrillation.
right, because once the Lucas is on, you can't stop the Lucas and then say, let me put those AP pads on. So it's AP pads first, Lucas, which we use, and then, okay, it's a refractory case. Now we're going to go AL, and without really reducing the chest compression fraction that we're trying to strive for.
So we have to talk about the Lucas. So you don't normally hear mechanical CPR and high performance CPR spoken in the same sentence. In fact, I've heard both Tom Bouthillet and Seattle's Medic One program personnel say that when they attempted to incorporate the Lucas, they just wanted to throw it away immediately. So what are you doing differently, or how is your philosophy different from their philosophy?
Well, I would love for you to come to our 2 week sessions where we are bringing in new medics, and it's called PDC, where they have to go through and like learn our process for everything, and cardiac arrest is a big one. We are very maniacal about how that device goes on, and we have created videos that are on the Palm Beach County Fire Rescue YouTube channel. They're open access for everyone to look at. But basically, there's a very specific way that we make sure that that thing is going on without interruption. And so I do agree that what you'll see, if you had a video camera that people didn't know that you were watching, as soon as the Lucas like enters the room, people stop doing CPR. It's like, ah, the Lucas is here.
It's a
You
cognitive
really,
sinkhole sometimes. Yeah.
it is, it is, it is. And even when people are setting it up and we're about to like slide the back plate underneath, like you cannot stop CPR. Even when you're hooking the arms in, you can hook the arms in around the person doing CPR. So there are very few times that you actually have to stop. And we can now see on our coach stat exactly where the stoppage was for Lucas, and we can time that. And if any stoppage is over 10 seconds, that's an opportunity for improvement. Um, Now, having said that, I will say that we do focus very highly on manual CPR in the early phase. So we aren't just coming in right off the bat and putting the Lucas on. We're staying on scene. We're doing great manual CPR. So when you look at many of our codes, the Lucas is not going on anywhere near the early part of that code. And I'm a big believer, if we're going to get this person back, it's going to be early.
Sure.
Same thing for kids, right? So I really very firmly believe that you shouldn't be doing mechanical CPR just because it's there. It should be well thought out as to why you're putting it on and when you're putting it on. Because I still do think that done correctly, manual CPR is what I would prefer in a non-moving location, right? You're
Sure.
stationary, not moving.
I actually think that we need to do some more study on mechanical CPR. Right now, we've just kind of gotten to the point where we have accepted that it's a zero-sum game. It doesn't do any better from a broad perspective than manual CPR. It doesn't perform any worse. It's a utility, and expert opinion is that it is a utility. However, some of the data that we have is actually getting pretty long in the tooth on mechanical CPR. And some of those opinions are based on data that came out when mechanical CPR was newer. And our training curve has really improved. I mean, I can
Mhm.
remember when the service I worked for first got the Lucas, the neck strap seemed to be just a suggestion. It was often over the abdomen, or it started to pivot like towards the feet or toward the head, or it
Mhm.
wasn't even centered. People didn't know maybe to use a Sharpie to mark the top of the suction cup so they could track movement. And I think that we've become more sophisticated in our use of the
Mhm.
Lucas. I mean, you say that you have a process, and so I think that we need a refresh of data to see how we know that there is a huge learning curve in manual CPR. When you go from regular CPR to high performance CPR, we see an improvement in outcomes. So it stands to reason that there may be a similar curve with mechanical CPR. If you're well trained in mechanical CPR, you theoretically should see an improvement in its performance. So I think we need a refresh on our data.
Well, I think the best way to do that is to use the CARES registry. And I just I just dropped a video this morning on that. But when you look at their annual report, right, which I happen to have right in front of me up right now, they actually show you there are certain states that actually just say, hey, here's all of our data. And I had a LinkedIn post on the other day, and it showed that you look at some states, and I used California as one example because they had like a lower overall survival rate. And then I used Washington State, going back to Seattle, going back to your point, they had an almost double survival, out of hospital cardiac arrest survival. And I just did some numbers and I said, if California was as good as Washington State, and I think the number was like an additional like 16 or 1700 additional survivors in the state of California, if they were just as good. And the question is, so people are putting on LinkedIn, why aren't they as good? And it's complicated, right? But part of it is the way that Seattle operates and the way that they perform. Now remember, the state of Seattle, the Washington state in general, the entire year of 2023, they only had like 5,500 cardiac arrests. California had like 25,000. It's a smaller denominator, but they actually had a doubling of survival. And in part, it's because of how they perform when they get to the scene. I strongly believe that.
Okay, so you do incorporate mechanical CPR and you don't use epinephrine in shockable rhythms.
That is
So
correct.
what you're telling me is the strongest data that we have for the benefit of epinephrine, which occurred over a century ago when we affected rhythm changes in some beagles, isn't good enough for you.
What, 1968 data on 7 groups of 15 puppies each? And as my dogs are behind me, don't listen, doggies, where it was the most absurd data. By the way, those dogs were 10-kilo dogs, which is like the size of a 1-year-old. And those 10-kilo dogs were getting a milligram of epi plus bicarb plus all this other stuff. And the marker was that these dogs were awake the next day, right? That's the data being used. That's why we give a milligram of epi today in adults. And even though there's data out there to show that in shockable rhythms, epinephrine is not good, it wasn't good enough for the folks at the AHA to make that change. If everyone remembers the paramedic 2 trial, that's in the United Kingdom, England, where they took 4,000 people and they said no epi, even though the medics were giving what they thought was epi. It was like it was a blinded study. And then the other 4,000 people actually got epi, and that study showed, and this is a no epi versus epi in all rhythms, right? They didn't break out the rhythms there, but they showed that the epi group and the no epi group, neuro intact survival, no difference whatsoever. So that's what allowed us to say, okay, if they're not doing epi in this big, large trial, and here's the outcome, that's when we said, you know what? There's enough data out here to show, and physiologically, it makes sense that when you're in an electrical storm, why would you want to show the heart, another vasoactive substance that's going to make that storm even worse? And instead, let's start to use a medication that's going to actually protect the heart, and that being esmolol for the refractory cases. So no epi for the VF cases at all. And then in the refractory cases, meaning that you're now past the third shock, then in comes the esmolol. And there's a great paper years ago showing that esmolol in refractory VF, I think the number was it was 5 times survival by using esmolol. There's many, many papers like that. Double sequential, by the way, the first time ever it was reported was in 1998. And a guy had 5 patients in a row. All 5 patients walked out of the hospital normal. That was in 1998. In 2022, Sheldon study comes out, and now the AHA gives it a weak recommendation. Come on, right? There's a lot of information out there like that. So here,
Okay, so you brought up IOs. So what is your expectation of your crew when they get on scene? Should they look for a vein or should they just drill?
So I've changed my opinion of this over the last couple of years, and I've now changed my protocol. Years ago at NMSP, Dr. Mo Daya, legendary, EMS guy up in the Northwest, came up to the podium and he said, if you give amiodarone IO, you're wasting your time. I'm paraphrasing. And I said, what is this guy talking about? That was years ago. And then in 2023, another paper came out and it showed the same thing. It showed doubling of survival if you give amiodarone IV. And then another paper came out, showed the same exact thing. And I said, wait a minute. The reasoning is because the bone marrow is full of fat.
Hmm.
Amiodarone is lipophilic. It basically like attaches to that fat. And effectively, amiodarone becomes placebo if you give it through an IO. And so we have now changed our protocol language to say amiodarone IV preferred, not mandatory because obviously, and we're still putting in IO during arrest, but for the VF arrest, they're not getting epi, so they don't need that. And for the VFRS, they do need amio. So my preference would be IV amiodarone to answer that
Um,
question.
as an aside, I often talk about that practically speaking and pragmatically speaking in a cardiac arrest, we actually have data that demonstrates that time of EMS arrival to the delivery of the first medication into central circulation happens faster with intraosseous access. It doesn't matter how good you are at IVs, just from a timing perspective, you're going to get medicine circulating faster through an IO. What I think are kind of like paramedic flexes from people that think that they should just be putting EJs in instead. And I think that these people are kind of afflicted by the knowledge curse in that maybe they're competent at EJs. And so they don't really have this concept anymore that most people don't insert EJs on a regular basis. Most patients in cardiac arrest don't present with EJs that should be attempted. What do you think as far as looking for an EJ before an IO?
Yeah, I think that those people I personally love the EJs, and it was my go-to, right? But I would say that most people should not be looking for EJs. I'm a big fan of the IO, and now with the caveat. So if you look at if you really know the timing of what happens when you get to a cardiac arrest, and you see when in that spectrum you're even going to be giving the first drug, you have several minutes. Like, for example, when you look at all the data on epinephrine, even in the ALPS trial from many years ago, even in the Paramedic 2 trial, epinephrine wasn't getting on for like 15 or 16 minutes, right? That's a long time. We recommend that you should be getting your epinephrine on in the non-shockable rhythm within 5 minutes. And Paul Banerjee showed that, and he showed his survival go way through the roof, especially with kids. So I ask you the question, can someone look for and get an IV within 5 minutes of arrival on scene? If you haven't, again, if you're out there and you only have like one medic and one EMT, and I get it, that's not going to be easy to do at all. But in my system, where I have 7 people plus an EMS captain, and I have ultrasound, we have everything. We should be able to get an IV on within 5 minutes. And so if someone can get amiodarone on a shockable patient within 5 minutes, I think that's a win. Yes, I agree with you that IO is faster no matter how you cut it, because you can't really miss it for the most part. But I think that giving it to an IO, amiodarone per se, and it just staying in the bone marrow and it being worthless, and it's like you didn't give it at all, I would say it's worth the extra minute or two of getting the IV. And if you're one of those people out there who can get an EJ, go for it. Have a good day. Um, I don't really care. I just want you to get the medication in successfully, and it not take 15 minutes. It should take 5. And you ought to
Okay.
measure that, by the way.
Okay. So here's one of the big questions that we haven't gotten to yet. SGA or endotracheal tube?
So we do SGA on everybody first. We come with the BVM, we give 2 big breaths, and then we have a separate person, our number 3 person in the triangle, and we use the eye gel. And we like the eye gel. There are some downsides still to the eye gel, and the eye gel folks know what I'm talking about. I'm happy to talk about them here. So it's not the perfect airway, but I think it's the best SGA out there. At the same time, we allow our folks to upgrade the airway, but we have recognized that if you want to get the first 5 minutes done and try and get this guy back to life, it's high performance CPR with effective, good BLS care as the backbone of that. Getting in the eye gel, and we use a 12 French Salem stump. Now the eye gel goes up to 18 French. I heard with the eye gel plus. I think we don't have those yet. But basically, um, we are going to a supraglottic airway first in pediatrics and in adult patients, with the opportunity to upgrade if for whatever reason that patient needs an upgraded airway.
With the eye gel, I know what I see is that the most frustrating aspect of eye gel is that there seems to be a seeding problem with it. And to me, there is a training curve with the eye gel, just like there is anyone else. And so I think the eye gel just does not withstand the pressure of people leaning on it as much as
That's
other
right.
airways do. And so I think when you start educating your personnel listen, you have to literally hold the bag and avoid pushing down or using or allowing the eye gel to become a fulcrum. If you
That's
can
right.
do that and if you can secure it properly, then you're going to get through that initial frustration with the eye gel.
You said it perfectly. And we put videos out on this thing. And well, what a lot of people don't understand with the eye gel, the adult ones anyway, come with these little hooks and a strap. That's because the eye gel needs to have pressure downward. The Thomas tube holder, the lateral pressure when you're doing CPR and that thing unseats itself by a couple centimeters, now you're having ineffective ventilation. You're not oxygenating the patient correctly. And then, as you said, if you do it the other way, where you're putting too much pressure and you bend it, now you're having a problem. You're not getting an entitle reading, which many people have reported back. So it's like a Goldilocks. Eye gel is like a Goldilocks. It can't be like not seated well because then it'll just push out. You have to have just the right amount of downward pressure without bending that curve on the eye gel. So you really have to train on it. You have to explain it, and it is a skill. Whereas the ET tube is the best airway, period. End of story. I still think people should know how to do it. We still do it quite a bit. If you're doing it, you should be it should be with VL, which should be recorded, which should be under a CQI umbrella, that you
Yes.
need to be reviewing all of those things, right? So again, it's just part of that high performance, that you shouldn't be doing something that you're not so good at. But I do agree that intubation in a perfect world is the best airway. And period, hard stop there.
Sure. And I hear people say that all the time. Well, intubation is the gold standard. Anything being the gold standard doesn't mean that you should perform that intervention. It doesn't mean that it's
Correct.
indicated. And we tend to look at a lot of these things, and this is a common thread in a lot of my content when I'm not talking about something that's evidence-based, is to start pushing through thinking traps and fallacies. And so we get into these traps of looking at things in a binary fashion. Should it be an
That's right.
SGA or should it be an ETA? When in fact, there should be a progression to our thinking. In fact, if you look at the PART trial and go back and look at the Rock Prime trial, they actually show that no advanced airway of any kind had the highest survival. Not that it was built to make a finding that you shouldn't place an advanced airway, but that you should be looking at this specific cardiac arrest as its own separate thing that's not related to any other cardiac arrest that you've ever been on. Are you able to ventilate this patient? Are you getting chest rise? Are you avoiding gastric insufflation? You don't may not need to put anything in there, because it's very possible that in 2 minutes you're going to defibrillate this guy, and then 2 minutes from then he's going to sit up, and he may
That's
not
right.
need anything in his airway at that point. And so you really have to
That's
evaluate each case. You get a guy that maybe was a CHF patient, went into cardiac arrest, and he had pink frothy sputum coming out of his mouth. Okay, well, now this is a backwards scenario. We need to prioritize getting definitive airway control in that patient, but it's very patient specific.
And what you just said brings up the bigger point, which is that when you look at all of these studies, and even if you look at your own data, like at your agency, cardiac arrest is so multifactorial. The reasons people go into cardiac arrest is so different and variable. When you get to the scene, like you said, you could get there early. You could have gotten there and there was a bystander, then the police was doing CPR, and then you get there in one shock and you're good. That doesn't mean that BVM was the best airway for that patient. It just meant that this patient had a great link in the chain of survival all set up for you, and you came and you took the baton. But it wasn't specifically the airway mechanism that made that happen. It was all the other things that made it happen. So it's very hard to, when they look at all these studies, and Henry Wang and Marianne Garcia Hale are doing another part study in pediatrics, but it's very hard to say that one singular thing made the difference in this aggregate data set, right? And that's why I would say take everything with a grain of salt when you're reading these studies. But at least now there's EMS level studies, out of hospital studies that are looking at these things, which is really what I've been pushing for a long time. But going back to your initial question, I think there's no doubt in my mind that it ought to be a progression from BVM to supraglottic airway, and then you should upgrade it as needed depending on what you're seeing and that patient's giving you back.
We are running towards the end of our time here. So what I want to do is give you an opportunity to bring the receipts. What are Palm
Yes.
Beach County's fire and rescues numbers?
Yes. And listen, the receipts matter, right? So
Yeah.
if you're going to go and you're going to talk about your like what you're doing and your crazy things you're doing, be transparent, right? So when people come to me and say, "Hey, what are you doing?" I said, "Let's take a look at the numbers." And here's the numbers. Year to date, we've worked 560 cardiac arrests. Remember, we see 160,000 calls a year at Palm Beach County Fire. Our overall survival, this is all rhythms, it's 13.1%. And nationally, year to date, because I have access to all the CARES data year to date, is 7.5%. So almost double national overall survival. And then, as many people know, they break it down into Utstein. And what is Utstein? That's the group of patients, about 20% of all the arrests you'll see in your community who are shockable, but then they're witnessed as well. So if you have a patient who's witnessed arrest and you get there and the initial rhythm is shockable, though that's the bucket of patients that should have a very high or the highest chance of survival. And in our particular case, we're at 41%. Nationally, it's 23.9%. So again, almost double. Then there's the unseen bystander survival, meaning that witness and shockable, and before you got there, a bystander doing CPR. That should be the most folks coming back alive. And in our case, we had 38.5%. Nationally, it's 27.2%. When you ask me, "Hey, Pete, what was it? Was it the fact that you're doing high-performance CPR or early defibrillation, or you removed the epi, or the amio IV, or the double sequential, or the esmolol?" I don't know. I really don't know. And doing an RCT to assess one of those things is never going to happen. I don't think it'll happen successfully. It'll take many years and a lot of money. And so all we have now are these bundles of care, and our receipts are the CARES registry. So I think that it'd be nice if we were having a conversation where the city commissioners or the county commissioners, when they're looking at you as an agency, you have to bring your receipts to say, this is what we're doing, as an agency. One thing I'll mention, which I think is never spoken about, if I can real quick, which is what is the hospital doing? We see a lot of bad hospital care where we bring in a patient who is witnessed, shockable, we got Ross, and we get to the hospital and they totally screw the care up. So the hospitals need to be held accountable as well. And that's why later today, I'll be at one of our local hospitals, helping them understand what our expectations are when we bring you a patient who has ROS, what we expect to happen in the ED, what we expect to happen in the ICU, in order for that patient to walk out of the hospital, because that reflects on our survival at the end of the year as well.
I think that there also needs to be a better emphasis placed on the transition of a patient who is intra-arrest, even though we want to avoid transporting patients intra-arrest. We know that it happens. Yes. I think that, again, this is kind of the knowledge curse where people who don't transport patients when they work on scene think that everyone's doing that, when I think that more services in the U.S. are probably still transporting as opposed to working on scene. When you get that patient to the hospital, my experience is that there is a complete deterioration in the way that code runs. In fact, and I don't want to throw shade at hospitals, it's kind of a jack of all trades, master of none situation. I mean, you can't be perfect at everything until you decide to be, I guess. But I will talk to medics who have the option of either working on scene or transporting and ask them, does that emergency room run a better code than you do? And the answer is always absolutely not. Then why are you not working that patient on scene?
Right. There's a lot of reasons why they don't. Mainly is because if they call the code, now they have to sit there and talk to the family and wait for the police to show up, etc. And many agencies don't train on that. The average termination percentage around the country, it's in the CARES data set, it's 40%. I have to say, I'm embarrassed about it. In South Florida, it's 4%. We transport everybody. So I've worked over the last year and a half, and I'm finally breaking through. But people just don't want to do that for whatever reason. We've also went to the state. because the hospitals, and I agree, we don't want to throw shade at the hospitals, but we know one thing about hospitals, that if they don't have to do it, they won't. So if it's not a JACO requirement or DMV or some sort of requirement, they're not going to do it. So now we went to the state, we created a document called Resuscitation Centers of Excellence, and we're going to the CEOs of every hospital and say, if you want us to bring you cardiac arrest patients, you must do what's on this list. And it goes to prognostication and cooling, and it's got a whole list of things. I'm happy to share it with you. Then our goal is to actually make it so that someone comes in and evaluates whether the hospital is doing the right thing. Because right now they're just attesting to the fact that they'll do it. But if they're not doing it, well, we shouldn't bring them patients. And then lo and behold, that's what's going to make them do the right thing. So we're living in a very weird world where EMS is like a socialized aspect of medicine. We try to do the right thing. We're not worried about profits. Hospitals, unfortunately, they're worried about the bottom line. And if they're not required to do something, they won't do it. And I got plenty of stories to talk about how if it wasn't for someone on the EMS side calling and forcing them to do something for our patient, we would have had a lot more dead patients at the hospital level as well. So a lot of work to be done, but it's all data driven. And I think we can get there.
Dr. Antevy, thanks for coming on. Thanks for sharing your success with Palm Beach County Fire and Rescue and your survival rates there.
Thanks, Jimmy. I'm a big fan of yours, and thanks for getting the evidence out there to everyone on social media. Appreciate you.
All right.